Good morning or good afternoon, everyone. This is Alessandro from UICC. Welcome to this virtual dialogues. We're really happy to welcome so many of you in such a big numbers for this important topic. So today's virtual dialogues, it's about a very important issue on cancer control. It's drugs don't work. What can be done to fight the threat of antibiotic resistance for effective cancer treatment? This session actually was originally planned as part of the World Cancer Congress 2020 program. Obviously, the Congress did not happen for all the event that we know, but we are delighted to be able to offer this to you in this adapted virtual format. The dialogue is offered in collaboration with GARDP, the Global Antibiotic Research and Development Partnership, and is held in conjunction with the World Antimicrobial Awareness Week. Just a very quick ground rules, which probably everybody know by now. Keep yourself muted unless you are speaking, so we avoid any interruption. And please make full use of the chat box. There will be time for a question and answer at the end, so do start noting down your questions as our expert panelists speak. Without any further ado, I'd like to pass the word to our chair for the day is Ingrid Ross, the CEO at the Norwegian Cancer Society. Ingrid, over to you.
Thank you so much, Alessandro. So, dear panelists and members of the audience, my name is Ingrid Ross, and I am the CEO, Secretary General of the Norwegian Cancer Society, and I will do my very best to lead us through this webinar. So a warm welcome to this session that is, like you said, Alessandro, in collaboration with GARDP and UICC as part of UIC's virtual dialogues. So why this topic? Antibiotic-resistant bacteria poses a significant and growing threat to cancer treatment outcomes. People with cancer are more sensitive to infections due to the lowering of immune defenses, while surgery and modern cancer treatment put the immune system under immense pressure. As many as 1 in 5 Norwegian cancer patients undergoing treatment are hospitalized due to infections, and antibiotics are the main line of defense. So antibiotics are a key and indispensable part of cancer treatment that we have taken for granted. We owe it to our patients to ensure a better system to continue having treatments for infections at our disposal and continue to save lives from cancer. World Antimicrobial Awareness Week takes place in November every year, and the objective is to raise awareness on AMR, promote best practices globally, and to work together to address the spread of drug-resistant infections. So with this backdrop, the UICC Virtual Dialogues is an ideal platform to bring together experts, as we have done today, from the cancer and AMR field to discuss the issue and what actions need to be taken. Through this, we hope to raise awareness and ensure AMR is a high priority in the global oncology agenda. To set the scene for the coming discussions, we'll start with watching a short video. The film will show experiences with managing infections during chemotherapy and why this may be more challenging with AMR. So please watch.
Hi, my name is Yehuda Mate, and I am a medical oncologist, and I have the unique privilege of being able to practice both in the United States, where I'm currently based, and also in Botswana. And I think being able to practice in 2 very different resource settings has given me an idea of the global impact of antimicrobial resistance on how well I'm able to treat my patients. For most of my cancer patients, I prescribe therapy, especially cytotoxic chemotherapy, that causes myelosuppression. And so it really predisposes them to infections. And there are good guidelines on how we mitigate this risk. However, we do end up admitting a lot of our patients with neutropenic fever and or sepsis. And, you know, the mainstay of treatment is really initiating and predict broad-spectrum antibiotics promptly. Antimicrobial resistance, though, complicates the decision-making and the management for our patients now, and it's really created the need to be able to have antimicrobial susceptibility testing. So what I mean by that is that, we do initiate patients on antimicrobial testing, broad-spectrum antibiotics, but then we don't really know whether their infection is being caused by resistant organisms. And so there's really the need to be able to test for this. What this does is that it might delay the initiation of appropriate antibiotics if, for instance, the antibiotics that I initially prescribed doesn't actually cover the bug that my patient has. There are a few instances, though, where patients are pan-resistant to a lot of commercially available antimicrobial agents. And this creates a really difficult situation because these are the patients that get sick, really quickly and have difficult to treat infections. They end up in the ICU and have a prolonged hospital stay and even longer recovery period. And so for these patients, you start to wonder what intensity therapy I can prescribe for their cancer after they've recovered, because I don't want them to be back sort of so sick in the ICU the second go around. I think having said all of that, I think the magnitude of the problem is even much higher in low resource settings. And so there is a case of a patient that I had with HIV and prostate cancer who was receiving docetaxel and actually responding well to therapy. And then we admitted him for neutropenic sepsis. And we initiated broad-spectrum antibiotics right away and had him on fluids and sepsis protocol. And this is an unfortunate case because he ended up dying. And, I think we know that the risk of death with neutropenic sepsis is high, but part of the question was whether maybe we had holes in our antibiotic coverage, whether this patient who also has HIV had antimicrobial, had resistant organisms that weren't susceptible to the coverage we had. And so for me as a clinician, being able to practice in these settings, I think we cannot think about antimicrobial resistance without thinking about improving diagnostics for detecting these. I never got susceptibility back, and it's not available in a lot of low resource settings. And I think not being able to actually appreciate what the burden of AMR is in these settings is really harmful, because what ends up happening is that we start broad spectrum antibiotics, patients get sicker, and we throw the kitchen sink at them in terms of antimicrobial agents. And this only makes the AMR problem worse. But, I think it's really sort of shooting in the dark and hoping for the best and hoping we don't have resistant organisms. And so, just being able to work in these two different settings makes me realize that regardless of where my patients are located, the issue of AMR really has been not adequately addressed in the cancer community. And I think as we think about scaling up care, especially in low resource settings, I'm glad UICC is taking this on, but I think, this is really of utmost importance. And I think it would benefit patients and also for clinicians. It'll give us a lot of tools in being able to deliver the best care that we can for our cancer patients.
Okay, so before I introduce our first speaker, I would like to ask all panelists to be mindful of the time they have been given. And in respect of all the speakers, and also to get enough time for the questions in the end, I will actually turn on my camera when time is up. So if you see my face, then it's time to wrap up, actually. So I will try to keep track of time. And I will also like to encourage our listeners to put their questions in the chat. I don't think there's a Q&A box. I think it's called chat. So if you could please send us your questions, and I will try to get as much time as possible for those in the end. And to all, as Alessandro said, please mute yourself. So it is my pleasure to introduce our first speaker out, which is Dr. Manika Balasagaram. He is GARDP's Executive Director. He'll talk about the global threat of AMR and GARDP's serious bacterial infection program, with a focus on infections relevant to cancer patients and the need to ensure access to treatment for all. So the floor is yours, Monica.
Thank you very much, Ingrid. And maybe I'll just start by giving a quick introduction of GARDP. We're a not-profit organization that brings the public and private sector together to accelerate the development of new antibiotic treatments to address antimicrobial resistance and to ensure their responsible and sustainable access. Our focus is very much on the WHO priority pathogen list, which I'll come to later, but also to look at specific diseases and specific populations in need. And our focus is very much on late-stage clinical development. As I've said, we really work by building joint collaborative projects with partners, both in the public and private sector, and really look at delivering, I would say, R&D projects into access and ensuring their use at country level. And so looking at that endpoint really is for us what we would deliver and see as impact. Next slide. Just to give a bit of background, most of you may probably know this, but antibiotic overuse and misuse really has accelerated resistance, and this is just to be expected naturally. It's part of evolution, and bacteria will adapt to what is thrown at them. And obviously, with more antibiotics being thrown at them, there's obviously a bigger chance of bacteria obviously adapting to those circumstances. But it's important for us to realize that this is happening all across the world, including in high-income countries like the UK and US with well-developed healthcare systems. Next slide. We seem to have a slight delay on.
Monica, yeah, I'm trying. Voila.
Yeah, so just on the next slide, I think is probably just a reflection to say, why haven't we kept up therefore with the pace of resistance? Well, obviously, one of the major factors that is, I would say, a problem is indeed that the development of new antibiotics are, of course, scientifically challenging. They're risky. Many of the drugs that are currently in development, there's relatively little novelty and don't necessarily address the priority pathogens we need to address. But also underlying all of this is that antibiotic R&D is not an attractive investment. And as you can see from this graph, the net present value in terms of what you would expect to have as a return as a company basically implies that antibiotic R&D is just nothing more than a loss-making venture. And so, of course, this has had a significant impact in the R&D ecosystem, particularly in the private sector. Next slide. But of course, all of this is having a real-life impact, and it's important for us to understand that estimates are that around 700,000 people die every year around the world from drug-resistant infections. And this is, of course, is not distributed evenly. And I would also point out that there are specific populations at risk. So one obvious group that has been mentioned before are newborn babies, and between 200,000 to 300,000 newborn babies die every year from drug-resistant infections. But another are specifically vulnerable populations, and cancer patients very much fall into that category for two reasons: because of chemotherapy, but also because of the surgical interventions that are required as part of cancer care. And I think from this, we do see that, in fact, we are seeing an impact, including in high-income countries. I've put here figures from the EU and the US in terms of the burden from drug-resistant infections, but it's important to understand that this is probably much, much higher in resource-limited settings. Next slide. So when we talk about what are the priority infections, we tend to classify this as what's called serious bacterial infections. And these are typically the kind of infections you would see in cancer patients. And as I mentioned, both surgery and chemotherapy mean that this is a risk. And a significant number of cancer patients undergoing chemotherapy, for instance, will develop an infection. And therefore, antibiotic resistance is a problem. There's quite a large number of infections that have been noted, proportion of infections that are actually resistant to mainline antibiotics. So this is something that we do need to address. Next slide. And when I talk about serious bacterial infections, we typically talk about things ranging from complicated urinary tract infections to intra-abdominal infections to hospital-acquired infections, which can often even acquire after surgical procedure or for patients in intensive care, but also I would say what has been mentioned before, neutropenic sepsis. I think bloodstream infections are a particular challenge and particular problem to treat. And of course, now I think within the AMR field, there are some priority pathogens that have been identified. These are called the 3 critical priority pathogens on WHO's list. And these 3 that I've mentioned here, the Enterobacteriaceae, which is a family of bacteria, Pseudomonas aeruginosa and Acinetobacter species, are all becoming increasingly more difficult to treat with conventional mainline antibiotics. And many of the new antibiotics that are being developed don't actually fully address resistant strains of these infections. Next slide. Therefore, in terms of what we're trying to do in GARDP, but we have actually developed a program dedicated towards this. We have already started a project with a company called Venatorix, and this is currently now in phase 3 it's a new chemical entity called Cefepime-taniborbactam that is really being developed for serious bacterial infections. And it's something that we aim to scale up the development, both in developing and high-income countries. We are also looking at other antibiotics in the pipeline, as well as, in fact, now combinations of older antibiotics that could be used to address these serious bacterial infections that I mentioned. Next slide. But of course, what I would finish off by saying is that all of this is important, but all this research and development, I think, would be really in vain if we are not able to ensure access. And unfortunately, access to antibiotics that are critical in the management of patients around the world, including cancer care, is lacking. And every year it is estimated that over 5.5 million people die from lack of access to antibiotics, particularly in low and middle income countries. We need to remember that many of the cancer deaths that are occurring around low and middle income countries, and that's a majority of cancer deaths, may be related to infections. So it's something that we do need to address, especially since many of the new antibiotics that are being developed, and if you look at what's been done over the last 20 odd years, very, very few of these new antibiotics are registered in more than 10 countries or made available in more than 10 countries. So this is a major gap. So if you go to the last content slide that I have, what we really show here is what GARDP is doing. Next slide. What GARDP is really doing to try and address access. And there are several different things that we're trying to address, ranging from licensing to global regulatory strategies to generating more evidence for public health policy and use, to really looking at manufacturing, as well as procurement and reimbursement models. So I don't have time to go through all of this, but we're working with other partners to really try and address these different challenges that we're seeing in access, to ensure that the work that's done in terms of developing new and improved antibiotic treatments will result in actually improved access for patients around the world. So if you go to my last slide, I'd just like to thank all our supporters and funders that has really made our kind of collaborative partnership model possible over the last years. Thank you.
So thank you so much, Monica. We will see you at the panel in the end. But now I would like to introduce Daniel Berman. He leads the global health team, including the Longitude Prize at Nesta Challenges. He will present the Longitude Prize report. What's the impact of AMR to cancer care and why rapid diagnostics must be a part of the solutions? So Daniel, please.
Thank you so much. And I'd like to begin by thanking the UICC and GARDP for inviting me to present the results of this research that we did amongst oncologists. What I'd like to start with is just to mention that I'm with Nesta, and Nesta is an innovation foundation based in London. And the part of Nesta that I work in is called Nesta Challenges. So what we do is we design and run international competitions, always focused on trying to solve a social problem. Next slide, please. So here, actually, the Longitude Prize is one of our biggest competitions at the moment. It was launched in 2014, and it is a competition which is designed to incentivize rapid diagnostic tests, which will be accurate, rapid, affordable, and easy to use, specifically to eliminate unnecessary use of antibiotics and to better steer the use of antibiotics. And I'd just like to mention that today we have 54 competitors from 12 different countries, and they're working on things like urinary tract infections, identifying pathogens, resistance, to know basically which antibiotic will be effective the first time around. Next slide, please. Okay, so here we come to the crux of the matter in terms of my presentation, which is research that we carried out among oncologists. I think that it's important to mention that this work was actually inspired from colleagues and friends in India who reported the detrimental effect of antibiotic resistance in terms of survival in the cancer patients that they were treating. I know we're going to hear more from React about that, so that's all I'll say. But it's a look at what's happening amongst oncologists and their patients in the UK. But really, we're thinking internationally, because we know that this phenomenon that I am reporting is a lot more advanced in some countries with high levels of resistance. So this report was why we embarked on this, is to raise awareness about this specific instance of how antibiotic resistance impacts treatment of people with cancer, and shine a light on what is going on specifically in the UK vis-a-vis what we know is going on in other countries. And finally, to encourage increased support for R&D and access/procurement for both antibiotics and diagnostics. The last thing I have to say before I give you the results is it was quite a large sample, because in the UK there's about 900 oncologists registered, and in this this research we had responses for about 100 out of the 900 total. Next slide, please. And you'll see in the chat, if you're interested in the full report, you have the link in the chat right now. So the first and overview finding is that 95% of oncologists polled are worried about the rise of drug-resistant bacteria and what it means for future cancer treatment. So if we dig down a little bit, what does that concern mean? 4 in 10 UK oncologists had seen a rise in drug-resistant infections in the previous 12 months. So I mentioned it's 100 oncologists, and the survey, when we say 12 months, it was December of 2019 through February of this year, so pretty recent. 56% agreed that they do worry about the future effectiveness of cancer treatment as drug-resistant infections increase, and almost half of those polled say they believe drug-resistant infections could make chemotherapy unviable. I know that is tough to hear, and it is a bit scary, but that's why we feel so strongly about knowing exactly what's happening in order to join the communities of people working on cancer and AMR. Next slide, please. So these are very high-level results. I would encourage you to look at the whole report, but the other thing that I wanted to mention is we looked at a few specialties. So we asked the oncologists, in terms of kidney cancer, skin cancer, and bladder cancer, in the last 12 months, have you seen a rise in resistance? And the results are pretty scary. Let me be clear. We're not saying that resistance is a problem in 78% of patients. We're saying that in each of these categories, this is the percentage of patients that the oncologist is seeing the rise in resistance. So they didn't say how much, but they said that 78% of their patients that they were treating for kidney cancer showed levels of resistance. So it's the phenomenon is growing. More than a third of cancer patients require surgery, which has been mentioned, and 5% of those surgical patients currently developing drug-resistant infection. So again, this is in the UK, and so we're seeing that the problem of immune suppression with chemotherapy, and this is obvious, I know, because for those of us in this field, but the problem in the UK is much, much larger in terms of chemotherapy. Next slide, please. And so to conclude, I'd like to say that fortunately, relatively speaking, the number of drug-resistant cases are still low in the UK. And this doesn't make it easier for individual patients that are faced with resistant infection, because as I said, it is scary and it is significant. But as an overall phenomenon, although the oncologists reported to us that it's increasing over time, it's still nothing like what we're seeing in India or other countries. Resistance to antibiotics is, of course, having more impact on countries with higher levels of resistance. Finally, I'd like to say diagnostics will not be a panacea, but as we've already heard from Dr. Yehudi Marte, diagnostics are going to be absolutely critical to know what pathogen and how to best treat them. Thank you.
Thank you so much, Daniel. So our next speaker is Dr. Amal Almani. She is the director of the Central Department of Infection Prevention and Control at Ministry of Health.
Ingrid, you're muted.
Sorry, the technical things here, sorry. So thank you, Daniel. So the next speaker is Dr. Amal Almani. She is the director of the Central Department of Infection Prevention and Control at the Ministry of Health, Sultanate of Oman. She's the focal point for the global AMR surveillance system and responsible for Oman's national surveillance system for AMR. Dr. Almani will talk about the importance of surveillance and good data and give us some experiences from Oman. Please, Dr. Almani.
Thank you very much. Thank you for inviting me to speak about Oman experience and mainly the national program in addressing the growing problem of the antimicrobial resistance. Next slide, please. I'll be focusing to be more comprehensive on the surveillance aspect of the program, and this is part of a different comprehensive measures to tackle the growing problem of antimicrobial resistance. The surveillance is one big part of it, where it should be addressed in both human health and also in the animal sector. But unfortunately, the other side is lagging behind, and we are continuing to build on the human antimicrobial surveillance system. Next slide, please. Why do we need surveillance in AMR? Other than that people does not believe on anything other than the data, the burden of this problem has to be estimated very accurately so that we can know the impact, and the impact from the point of prospect of the morbidity, mortality, and economically on each nation and globally. There has been evidence that establishing a surveillance system in any country or in any nation would indirectly also help in reducing the infection rates as part of the governance of this growing issue. Monitoring the effectiveness of any measures that would be implemented in tackling the issue, and it's part of the patient safety initiatives and programs. Next slide, please. So if I take you through the experience of Oman, we started actually from no surveillance at all for the AMR. And the biggest challenge was how to standardize the language. Each lab was speaking a different language when it comes on how to report the antimicrobial susceptibility. So that was the bulk of work at the beginning of the effort in establishing the surveillance system. And from there, we started to work on the protocol of the surveillance. We did initially go with the old traditional way in doing the surveillance by asking the people to fill on Excel sheets for the data and fill in the results of the lab. But when we piloted it, we thought that this would prohibit the ongoing surveillance and would be dependent more on human factors. So we decided to utilize an excellent system that we have, excellent electronic medical record system, and implement it within the lab system so that we can pull the data directly from the labs to this system. And then from there, we put on our definitions for the interpretation of the resistance and together our data for the reporting. And my message from here is that an effective surveillance system is the one that can be integrated into the available resources, and don't wait to build up resources that you don't have, otherwise you would not move forward. This had helped us really to issue the first report of our OMASS, Oman antimicrobial surveillance system in 2017. And since then we had also the 2018 report and working on the 2019. Next slide, please. So we are getting the input for this system is from the laboratory-based data on the ASTs for all the bacterial, and now we included Candida. We are also getting the data from the Central Public Health Laboratory, which is the surveillance site for pneumococcal, enteric pathogen, genital pathogens, and also a reference lab for the Candida auris. In terms of the antimicrobial utilization, we are getting it from all the healthcare facilities in Ministry of Health where they are linked to the electronic system data. And we have a reporting system for any newly emerging AMR that the hospitals has to report it through this reporting system. The next slide, please. With this, we are able to generate reports for the Sentinel hospitals that is part of this surveillance system on an annual basis, and also a comprehensive annual OMASS report. And from the same data, we are sharing with the GLASS, the Global Antimicrobial Surveillance System, and we have been also giving report to about the antimicrobial utilization for the governorate, which is the different districts in Oman. The other thing that we have made to help the hospitals is that we have put in the system or the data sheet for them within their electronic system. So if they want to monitor for outbreak, the spreadsheet is there in the hospital system and they can do it on more frequent basis. Next slide, please. So this is to show you how the hospital report looks like in comparison, and we are benchmarking it with the national data. So in times of the MDRO, we give them all the specimens, including the screening, blood, and urine specimen, and we compare the rates to the national bench rate. And a graph that shows the prevalence of those organisms throughout the year, so if they want to detect an outbreak, and a descriptive tables about the sources of the infection, whether it's community or hospital acquired, and the percentage and the mortality of each organism. The next slide, please. This is how the AMU reporting looks like. So with graph, we graph the most frequently used antibiotics, and this is has helped us to see where is most of the utilization going on and whether it's appropriate or inappropriate, and to address it in the intervention. Next, please. This is again the AMU, which is the antimicrobial usage by different institution, colored. So we would see if there is particular institution where the certain antibiotic is more used than in the other institutions, and what could explain that, and we investigate it. Next, please. Of course, from all this data, we generate an annual antibiogram, and this is very helpful for the clinician on the ground because they know where to go when they want to prescribe antibiotics as an empirical coverage. Next, please. And this is to show you how actually the MDRO percentage correlate with how the hospital's doing in terms of infection control. The slides on the right side is for the compliance with hand hygiene, and you've seen the hospital that is mentioned there, and you can see how is their performance is the highest in time of the prevalence of the MDRO. Next, please. So this is my last slide to say here that, following changes in AMR trend with intervention is all what stewardship is meaning. And unless you have this data, you would not be able to assess the impact of your stewardship program. The antimicrobial resistant is not anymore the issue of infectious diseases or infection control individuals or the microbiologist. It's becoming the nightmare of everyone. And it's the number one threat for every human being. Taking an action based on data is the best way to go. And this is a call for all sectors and nation to intervene before it's too late and to take a One Health approach to the problem. Thank you very much.
Thank you so much, Amal. Really interesting. So our last speaker is Dr. Sujit Chandy. He's the director of REACT Asia Pacific, and he's also a professor at the Department of Pharmacology and Clinical Pharmacology at Christian Medical College in India. Dr. Chamdi will talk about the need for all relevant stakeholders to come together and collaborate, and how the cancer community can help towards addressing the issue and improve cancer care outcomes. So please, Sujit.
Thank you very much, Ingrid. And my thanks to UICC and GARDP for this opportunity and privilege to share my thoughts on this very important topic. Next, please. So, I mean, for a long time, many people believe that communicable diseases and non-communicable diseases are poles apart. One, the infectious diseases, something which is reminiscent of the previous century, maybe, and the non-communicable up and coming. But as we all know through this current pandemic, how important to look at both communicable and non-communicable. And it's not just the fast pandemic which we are facing now, which is important. We do have the slow pandemic of AMR. And as you can see through this slide, the interesting thing about this whole aspect of non-communicable disease like cancer and communicable diseases like the infectious diseases is that antibiotics are needed in both. And interestingly, it's not just the antibiotics which are part of regimens for cancer, but also, as many speakers pointed out, when there are infections because of immunosuppression. Next, please. So the problem, therefore, is huge, I feel, from a cancer patient point of view, because chemotherapy regimens and the therapeutic efficacy may be affected. And we also have this huge problem of whether the antibiotics we give for infections are effective, especially when there are resistant bugs and superbugs. And that may lead to longer stays, more complications, higher costs. And please remember that these patients have already invested a significant amount in their cancer therapy, and this whole issue that they cannot work, and so many other costs are there, both hidden and not hidden. So this probably will therefore, when these drugs don't work, lead to quite a bit of a difficulty for both the healthcare professional as well as the patient morale. And this could have a significant impact and consequence on the entire process of what you live and work for. Next, please. And therefore, I think it's important that all stakeholders come together. And if you look at the first diagram, you'll find that, you know, this whole issue of One Health as far as AMR is concerned, because antibiotics are used in the animal world, in the human world, and of course, it's there in our environment, whether we like it or not. So therefore, all stakeholders have to come together on one platform. But from a human health perspective, whether we are patients or prescribers or the pharma industry or basically people who use antibiotics, it's important to remember that we don't have too much time. And that's why the whole healthcare system has to be strengthened, whether we belong to the healthcare providers or the government or the public or just an activist or an NGO, health insurance system or policymakers. We need to be sure that we are on board with realizing that antibiotics will soon become ineffective, and they already are. Next, please. But you as a cancer community have a special role to play. One is, of course, with your patients and within your hospitals. And therefore, this whole phenomenon, if I can call it, a concept of antibiotic stewardship, we need to preserve and to conserve the antibiotics for a more effective future. So you need to educate your staff that or your juniors, for example, that don't use antibiotics unnecessarily. We need to be sure that when we invite others through an interdisciplinary approach, that they also need to know about antibiotic stewardship. Of course, IPC, infection prevention control, is so important in today's setting, especially in low resource settings. And then the whole judgmental value of when we should prescribe an antibiotic. Should we go by the protocol, or should we make sure that our patients somehow don't get the risk? These are all hugely sometimes debatable issues when it comes to AMR. And therefore, we need to have a real clinical acumen that, okay, we cannot risk it anymore. Therefore, we may have to give an antibiotic in sepsis, definitely, but also in neutropenia. but the protocols therefore are important. And then, of course, is this whole thing of, as Dr. Amal was mentioning, about surveillance. We need to build the evidence that, are we misusing it in a particular unit? Are we going overboard with it? Only when we are able to monitor it will this come out. And WHO has come out with a beautiful antimicrobial stewardship toolkit, especially for lower and middle income countries, which I think is useful for you to read. It's available on the next. Next, please. And I think, therefore, I'd like to bring home the point to the cancer community, to you, that the Global Action Plan has given a platform for us to act in this area. And though awareness, knowledge, and evidence, infection prevention control, optimal use, and innovations in R&D and leadership are important pillars, you as a cancer community, I think I would urge you to raise awareness within your teams, within your hospitals, that if we don't take care of our antibiotics and use it wisely, then we ourselves are in trouble. With your patients, because patients, remember, they are human beings just like you and me. And when they're out of the hospital and if they're at home, they may just self-medicate with an antibiotic when they have a cough or a cold. So that raising the awareness is important. We already mentioned that monitoring and improving antibiotic use is important. IPC is important. But more or less, remember that you and I will be here only for a short time. That hospitals need guidelines, and these guidelines have to be implemented. And that is crucial in my opinion. Otherwise, it's you and me. I can do it this way, somebody else can do it this way, and there's no safeguard there. Monica mentioned about innovation and research, so crucial at this point where we're really running out of newer antibiotics because the business models are not working. And therefore, we need to be advocates, not just with policymakers in our hospitals, but with our governments, with the financing groups, that somebody has to finance the antibiotic pipeline. Somebody has to finance the diagnostics. Otherwise, we are in big trouble. We means who? It's your patient. It's you as a healthcare professional who's struggling to make sure that this cancer does not spread. And so you give all you can get. It's not just the patient. It's not just you, but you as a person who could also get an infection. And therefore, let me end by the next slide by saying that the challenge is really, can we save the antibiotics that save us? I think you have a big role to play as a cancer community. And I think that if you take on board the challenge, other groups and other associations will follow. Thank you very much.
Thank you so much, Sujit. And you can just keep on having your camera and your microphone on, because now we're going over to the panel discussion. And thank you to all our panelists for their very interesting and valuable contributions. So I will try to check actually the chat box. While I'll do that, I will please ask all the panelists also to not just turn on the camera, but also unmute, so it's possible for us to have a discussion. And I will actually start off with one general question to all of you. We could maybe start with you, Monica, and then go the way around. And it's actually a question that also Susan Kiru asked in the chat, but I also thought about the same thing. So why is there so much innovation for cancer care, but such little progress in finding new antibiotics or new ways to treat these bacteria? So Monica, please.
Yeah, I think that's a good question. I'm not sure I can entirely answer it, but one of the slides I alluded to probably is a good indicator on why there's so much more investment and research in development to cancer care. Obviously, it is cancer, I would say research and development is a big part of the innovation sector. And it's perceived as having huge incentives. And if you look at the net present value of cancer in chemotherapy, it's extremely high. While in the antibiotic space, this is really seen as loss-making. And what that's really resulted in is a very large withdrawal and a disinvestment from the private sector. However, I would also add that there has been a disinvestment from the public sector. If you look at research in infectious diseases over 3 or 4 decades, in the public setting, that has obviously changed over time in relation to other, I would say, disease areas. And so I think it's a combination of those that has led to, I would say, lack of basic research, a lack of investment in translational research, and obviously then more downstream into clinical research and development. This is still an issue. And I would say the other problem, of course, is that when we talk about antimicrobial resistance, we're talking about many, many different types of bugs. We talk about many different types of diseases or syndromes we have to develop indications for. We also have to look at many different types of populations, and this adds to the complexity of this whole picture and why it remains a challenge to discover and develop new antimicrobials.
So Daniel, do you have the same point of view here?
Well, I'd like to touch on something a bit different, which is diagnostics, since that's the space that I'm in. And it's similar to what Monica was saying, but I think there are a couple of important differences. So one is that there has been this idea that, oh, if you can buy an antibiotic and it costs less than a diagnostic, then why would you buy the diagnostic? And so we have to deal with that economic reality for people, because as we know, antibiotics are widely available, and it doesn't always go through a physician. But closer to cancer, I think what I would say is that there's things are really popping in terms of the technology. So technologies that have been evolving for a long time, and now with COVID, COVID is a terrible tragedy, but it has meant that there's huge investment in diagnostics, but so far not in the AMR space. So I think the trick is how, as Monica said, in terms of he mentioned in terms of R&D, but we need a willingness to spend money, and I think the cancer community can help, and we can join together and really talk about what's the value and what difference will new diagnostics make.
Perfect. Please, Amal.
Yeah, I'm just going to add something else, which is that we have created smarter bugs. That it's really very hard for the industry to find a new mechanism where their antibiotic can act. Because even with the previous invention of antibiotics, they have been really around the same mechanism of action. They are not innovative per se, that they would go into a different direction or a different pathway of acting on both sides, whether with the gram-negatives or gram-positive bacteria. And in order for the industry to go for an innovative pathways in providing antibiotic, it's really, really expensive, because they would go into the genetic side of inventing an antibiotics that can overcome all those mechanisms of resistance that has been developed by the organism. On the other side, when they take all that burden, including the financial burden, we restrict the use of those antibiotics because we want to save them. We don't want them to go to the same fate that the previous groups of antibiotic has gone through, and being overutilized, and then we would again run into the resistance. And that's why I think, inventing antibiotics or new antibiotics is only buying time for a comprehensive measure in tackling AMR. The other sectors should also play their roles in terms of the environmental management of the AMR, and in terms of the agriculture and the husbandry section and animal sectors, where there is a lot of AMR going on there unseen until it comes and knock the door of the human side as a diseases in human beings.
Sujit, please.
Yeah, very quickly. I think there are the business model is obviously a difficult model at this point, especially when you have chronic medication and chronic diseases coming in so rapidly, and this is lifelong therapy for them. So obviously there's more profit there. The second is, as we all know, that we're supposed to, take antibiotics for a particular course. So it's not that long, and then people don't take it for the full course. And then, of course, there's always the risk of resistance, and therefore it's a very high risk business if you're going to invest in antibiotics, and that's part of the problem. And I do agree with all the other points that the speakers said.
Perfect. So we have a question here from Nilima, and I think I'll actually ask you, Amal, because you touched upon this. So how do you decide that antibiotic is prescribed unnecessarily?
So that comes back to Daniel's point, improving our diagnostics. Most of the time we run into overuse of antibiotics because people do not have the appropriate diagnostic to avoid them. That's why every runny nose and every cold in a GP office is a bacterial infection that warranted an antibiotic prescription. But say, for example, if that GP has a strep antigen or a strep bedside test, and he would do it for the patient and find that he have a strep throat infection, that would be a directed therapy with antibiotics, and he would diagnose the infection and then rule out that it's directed therapy towards that infection instead of giving blindly the antibiotics for that patient. Most of the clinical guidelines to differentiate between viral infection and bacterial infection is not really specific, I would say. They might be sensitive, but they are not specific. And that's why to make them more specific, we need to develop our diagnostic and help our end user. We can't just be asking for proper utilization of antibiotic and we don't have the proper tools to direct this utilization.
Thank you very much, Amal. That was a really excellent response to that question. So, Sujit, there might be special challenges that low and middle income countries have to deal with when they are facing antibiotic use. So could you please elaborate a bit on that?
Yes, thank you. I think there are multiple problems. And one is, of course, this whole diversity in most low and middle income countries with issues of access and issues of excess. And you'll have places where there's not even a healthcare facility. So let alone a diagnostic, support. So therefore, this whole, wide spectrum of resources is a huge issue as far as healthcare is concerned, and it does impact antibiotic use and infection care. The second aspect is emboldening the population itself when it comes to empowerment of knowledge and action. So as you can see in many places, the infection prevention and control, or basic hygiene, let me put it that way, is a difficult challenge in many of our countries. And therefore, if you're not able to sort that out, you're bound to get an infection, especially when nutrition is low in many areas. The third basic problem I foresee is that many places there is law and policies, but often collective responsibility and social responsibility is poor. So invariably, people don't follow the guidelines or protocols in many places. And I do empathize at times when you don't have the proper supportive diagnostics or access and availability and affordability issues are there. Physicians will have to sometimes safeguard the patient by erring on the side of giving an antibiotic. But those challenges still remain, and therefore we do need to do something about it. And last but not the least, we need to remember that often individual good versus public good. Antibiotics are a public and precious resource. And we often tend to neglect that philosophy behind this, where we tend to think of individual good first rather than the entire world's good. And that's where we're going to land up in problems, not just in low middle income countries, but because of it being a global village right through the globe. Thank you.
Okay, so I see there is a couple of questions here in the chat, and if you have the time, you panelists, it would be great if you could answer in the chat, because we need to wrap this up with one final question to all of you. So if you could just share just one idea with the audience that would be the most important for them to remember about the things that we've discussed today, what would that be? So please, Daniel, could you start?
Yes, I think that what really stands out is this is rare. And so this coming together of people that are focused on antibiotic resistance and people that are focused on cancer, I think we've hit on all of the key things. And I hope that this is just the beginning, because to be honest, I've been in the AMR space for 4 years and this hasn't been happening. So it's really encouraging and it's a takeaway, and I'm quite positive and energized by this meeting.
Thank you, Daniel. Monica, please.
Yeah, I agree with what Daniel said, and I would add to that that we really very much hope that I think people in the cancer community can really act as strong advocates on some of the issues that we've raised, the need for better tools, diagnostics, whether they're diagnostics, drugs, even infection prevention control, better surveillance, and so on. We strongly need, I think, support, because antimicrobial resistance is such a big and complex field, and it cuts across all parts of the healthcare system. It goes into not just human health, but agricultural, livestock, and environment. And that's why, we really need to reach out and work with other, I would say, other areas and other communities, really to have an impact. So thank you very much for listening to us. And any ideas that you have, any support that you can give us, please do get in touch with, I think, any of the panel members. We'd be interested to hear from you.
Great. Amal, please.
I want to first thank you very much for inviting the Infectious Disease Committee and talking about cancer therapies and the challenge of AMR in cancer patients. What I can tell you that in the cancer therapy, you achieved a lot, and the science has really advanced so much that we need really to preserve this success, and don't let the AMR kill your patients after all you have done, whether in the chemotherapy side or even in the transplant and the advance in the transplant. And you should, as we said in the beginning, we all united against this threat to save our patients after all we have done in advancing their treatments and therapy.
Thank you, Amal. And last but not least, Sujit, please.
Yeah, I think what's important is that everyone have a personal, emotional connection to this. And we need to generate stories in the cancer community where people, your own patients, have had a very difficult experience. It could be a sepsis, and there's no antibiotic available which is effective, or it's too toxic, or they can't afford it. Those are very powerful stories. The second point I would like to make is you have an opportunity to bring in more data within your own communities and look at this and publish as a joint association. That will be extremely powerful for policymakers, especially that they know that cancer is going to be a huge issue. It already is. And last but not the least, I would say that we need to advocate with our own governments to do their part. It's not just GARDP or not just WHO or UN. Each government has to do their own part if we really have to pull this through. Thank you very much for that.
Thank you so much. So thanks to all our panelists for a very interesting and important discussion. And thanks to all our listeners that have been following this webinar and for good questions in the chat box. I'm very happy with that. And we hope that you've all gathered new knowledge about the impact of AMR on cancer outcomes and why we need great surveillance systems and the research and development work being carried out to actually get both new and improved antibiotics. And most of all, why we in the cancer community have to give this topic our very highest priority. So thank you so much. Goodbye, and thank you for listening.